Good morning, ladies and gentlemen. Topic of today's lecture is quite interesting. This lecture is my first lecture on hair disorders. Although there was a demand by different PG students about this lecture since quite some time, but unfortunately, I was not able to deliver talk on hair before. So today is my first lecture on the topic. There will be other lectures following because this is a big topic. And today's lecture will mainly cover the anatomy of hair and the hair cycle and approach to the patients with hair disorders. In my subsequent talks, I will be discussing the non-cicatricial and cicatricial alopecias. Then I will discuss the different causes and management of hypertrichosis and hirsutism, then the hair shaft defects and everything related to the hairs and the skin. So let's proceed to today's lecture. First of all, what are the different types of hair? Different type of hairs are produced by different kind of follicles. Every hair emerges from a follicle. The type of the hair produced in a particular follicle can change with age or under the influence of hormone. By this, it means that a vellus hair can convert into a terminal hair under the influence of hormone, and a terminal hair can convert into a vellus hair, again under the influence of a hormone. We are going to discuss all this subsequently. What are the prenatal hair? The prenatal hairs are called as the Lenuga hairs. There is a prenatal coat of fine, soft, unmodulated, and unpigmented hairs on body of the infants. Then postnatal hair. Postnatal hair are of two types. The vellus hairs. Vellus hairs are soft, unmodulated, and occasionally pigmented hairs, which are always less than 2 centimeters long. These are usually the hairs which are seen on bodies of females. Then the terminal hairs. Terminal hairs are long, coarse, and modulated and pigmented hairs. The terminal hairs are typically seen on the scalp, and also they are seen on the face and body of male. Female may develop terminal hairs in case of polycystic ovarian syndromes or other hormonal problems. This table shows the different characteristics of the Lenugo hairs, the vellus hair, the terminal hair, and miniaturized hair. So Lenugo hairs have a short anagen duration, that is 1 to 3 months, and are always less than 1 to 2 centimeters in size. The vellus hairs, they have an anagen duration of 1 to 2 weeks, and they are usually less than 2 centimeters in length. The terminal hairs, which are the usual hairs, have a long anagen period that is more than an year, and they can grow up to 100 centimeters. Miniaturized hairs are again like the vellus hair, have the anagen duration of less than 1 week and size less than 2 centimeters. Development and distribution of hair follicles. So this is a little bit of embryology. Human hair follicles appear first in the region of eyebrows, upper lip, and chin at about 9 weeks of embryonic development, and other regions of the body by 4th month. Full complement of hair follicle is probably established by the time of birth. The follicle density at the time of birth is highest when it may be similar across all the skin surfaces. So the follicular density is almost same on the face, on the body, arms, legs, etc. Many of the children are born with lots of hair, and the mothers are usually worried that the children have lots of hair. So you just have to explain them that this is gradually and slowly going to improve. With growth, there is progressive reduction in follicular density on the body as the skin surface increases, but the density remains the same over the scalp. So gradually and slowly, this follicular density, which is seen in young infants, reduces and becomes normal subsequently. Then the anatomy of hair follicle, which is our main topic. Here is the keratinized product of the hair follicle. The follicles are sloped into the dermis. You can see that the follicles are not coming out straight, but they are always coming out of the surface at an angle. So they are sloped in the dermis, and the larger follicle extend into the subcutaneous layer. Here in this picture, you can see the bulb of this hair follicle lies in the subcutaneous tissue. Erector pilae muscle runs from a point in papillary dermis. This is a point in papillary dermis to the mid region of the follicle wall. So erector pilae muscle is responsible for the goosebumps. Above the muscle, one or more sebaceous gland. You can see the sebaceous gland here. And in some region, apocrine glands. Apocrine glands are present in the axilla and in the groin, also open into the hair follicles. These glands usually open above the attachment of erector pilae muscles. Hair follicles are conveniently divided into two regions. The upper part, I have dissected, I have indicated this on a hair follicle. The part above this brown line is the upper part, and the part below the line is the lower part. So the upper part of the follicle is subdivided into the isthmus and infundibulum. And the lower part comprises of hair bulb and the suprabulbar region. Now the isthmus, this picture shows the infundibulum. The opening of the hair follicle is called as the ostium. And from the opening till the attachment of sebaceous gland, the portion of hair follicle is called as the infundibulum. And then from the attachment of sebaceous gland till the attachment of erector pilae muscle, the portion of follicle is called as the isthmus. And below the isthmus, this is the lower part of the hair follicle, which has the bulb and suprabulbar region. Now, this is the hair follicle in horizontal view as well as in vertical view. You can see this is a terminal hair follicle, and hair shaft is seen within the follicle. And this hair follicle itself comprises of the inner root sheath and then the outer root sheath. Here in the vertical section, this is the inner root sheath, this is the outer root sheath. This is the matrix from where the hair, inner root sheath as well as the hair shaft emerges. And this is the dermal papilla. This diagram shows the density of hair follicle in different areas. No hair is present on the palm and sole, so there are no follicles here. Then the lots of hair and especially lots of sebaceous glands are seen on nose and face. Forearm will have and back will have a moderate number of hairs, while scalp is full of terminal hairs. The upper follicle is relatively a constant structure. That is the infundibulum and isthmus. But the lower follicle undergoes repeated episodes of regression and regeneration during the hair cycle. So once I will be discussing the hair cycle, I will be discussing how this lower portion of the hair follicle changes with time. Follicular unit, this is important. On the scalp and in some other regions of the skin, hair follicles are arranged in groups of 3 or more follicles. Because of this arrangement, the hairs looks thicker. Several follicles within a follicular unit may coalesce so that the hair emerging through a common infundibulum. Each follicular unit is supplied by a single erector muscle which splits to encircle the entire follicle within the follicular unit. So this diagram shows the transverse section or horizontal section showing different follicular units. You can see these are different follicular units where there are 1, 2, 3, 1, 2, 1, 2, 3, 4 different follicles arranged together with their sebaceous gland. This is a bigger view. You can see 4 different hair follicles with the sebaceous glands, and this is one follicular unit. This is the actual diagram. You can see 2, 3, or sometimes 2 and 3, sometimes single hair follicle emerging from one follicular opening or infundibulum. Hair biopsy vertical and horizontal section of the upper segment. This is the ostium. This is the place of the follicle from where the hair shaft is emerging. The insets show horizontal section through the infundibulum. This is a section through the infundibulum and then the isthmus. You can see that the section through infundibulum, this is infundibulum has the skin absolutely like the skin of the epidermis, while the cross section through the isthmus will show the lining of a follicle. The infundibulum extends from the ostium. Infundibulum extends from the ostium till the opening of the sebaceous glands. Infundibular epithelium is similar to the overlying epidermis with a granular layer. This is the granular layer, and stratum corneum, which desquamates into the follicular lumen. So this is the stratum corneum, this is the granular layer, and rest is the epidermis. So ostium or infundibulum has the cross section similar to cross section of an epidermis. Then the isthmus. Isthmus extends from the opening of sebaceous gland till the opening of erector pili muscle, attachment of erector pili muscle. This is a multi-layered structure with outer root sheath that is continuous with the infundibulum, but now it lacks the granular layer and undergo the pattern of keratinization, which is called as the trichlemal keratinization. So this keratinization is homogeneous in contrast to the lamellar keratinization of the epithelium or epidermis. So this homogeneous keratinization, which is seen in the isthmus, is also called as the trichlemal keratinization. That is why the cysts which are formed in the region of isthmus, which are called as the pilar cyst, they will have this homogeneous keratinization, which is the trichlemal keratinization, and they would not have a granular layer as is seen in this cross section. Now, the hair biopsy and vertical and horizontal section of the lower segment. Note that the stem and the hair bulb deep to Adam's fringe. Adam's fringe is this area where the nuclei are replaced by the keratinization in the hair shaft. The portion above the Adam's fringe is the stem, and then the portion below the Adam fringe is the part of the bulb. Portion above the fringe will have the structure similar to the structure of isthmus, while deep in the portion of the upper part of the bulb will have some peculiarities which will be discussed later. The stem and the suprabulbar region. The region below the isthmus and above the hair bulb comprises of 3 layers: the outer root sheath, the inner root sheath, and then the hair shaft. The outer root sheath is multi-layered epithelium enclosing the inner root sheath, which at this level is a fully keratinized structure. Now, this is a horizontal cross-section through the through the lower segment, immediately above the Adam's fringe. Note the different layers of hair follicles, and the stain is Mason trichrome. So this is the inner root sheath, and the most interior portion of inner root sheath is called as the cuticle. Then there is the Hurley layer, then the Henle's layer. Cuticle, Hurley, and Henle. These three layers comprises of the inner root sheath. Then there are multi-layered outer root sheath and an adventitial covering, which is the external fibrous layer. The inner root sheath, as I've explained, consists of the cuticle, the Henle layer, and the Huxley layer, or Hurley layer. Outer root sheath. The most peripheral layer of the hair follicle epithelium enclosing the inner root sheath. At the lower tip of the hair bulb, it consists of a single layer of cuboidal cells, becoming multi-layered as the region above the hair bulb. I am trying to find. So I will explain this further. I think we have further diagrams. Yes. This is the outer root sheath, and in the hair bulb, it is a single layer, and as it progresses, the number of layers increases in outer root sheath. In beard area, there is a distinct single cell layer interposed between the outer root sheath and the inner root sheath, and this is known as the companion layer. So here, this companion layer is highlighted. This layer is between the outer root sheath and the inner root sheath. This companion layer is only present in the beard area, while rest of the hairs, they don't have this companion layer. Now comes the hair bulb. Hair bulb is the deepest part of the follicle. This is the hair bulb, situated in the subcutaneous fat in large hair follicles. Invagination at the base. This is invagination at base of the bulb, and this is called as the dermal papilla, which is connected to the perifollicular dermal sheath by a narrow stalk. This is a stalk. Dermal papilla is connected to the perifollicular sheath by this stalk. The hair shaft and inner root sheath. This is the portion where hair shaft and inner root sheath emerges, are derived from the epithelial cells surrounding the dermal papilla, known as the hair bulb matrix. This is the germinative layer or hair bulb matrix. This is the portion from where this cells are produced that later on forms the inner root sheath and the hair shaft. These cells have a high mitotic rate. So the inner root sheath and the hair shaft is formed by this single layer of rapidly multiplying germinative cells, also known as the bulb matrix. Keratinization of the inner root sheath precedes that of the hair shaft. So the black color shows the keratinization of inner root sheath precedes the keratinization of the hair shaft, and suggests that the inner root sheath has a role in molding the shape of hair fiber. The inner root sheath derives from the cell in the lower part, more lateral part of the matrix, whereas the hair shaft is formed from the upper centrally situated. So it is said that these few cells, the centrally upper located cells, they form the shaft, while the lateral cells form the inner root sheath. The outer root sheath surround the inner root sheath, and at the hair level of hair bulb, it is just single layer of cuboidal cells I've explained to you before. Now the dermal papilla. This is the dermal papilla. Dermal papilla is flask-shaped structure that invaginates in the base of the hair follicle. It is made up of specialized fibroblast-like cells, often contains loop of the capillaries, capillary blood vessels, both the arterial and venous blood. Connected to the dermal sheath, this is the surrounding dermal sheath, which is connected to the dermal papilla by this stalk. It plays an essential part in induction and maintenance of follicular epithelial differentiation. Now the dermal sheath. This is the dermal sheath. It is a collagenous layer that envelops the lower part of the hair follicle. Fibroblasts of dermal sheath are also specialized. So once we are removing the follicle at the time of hair transplant, we remove the follicle with this dermal sheath. Now the terminal versus vellus hairs. Horizontal section, note the diameter of the hair shaft and the inner root sheath, hair as well as hair. Usually the terminal hairs, the hair shaft diameter is more than the diameter of inner root sheath, but in the vellus hair, the diameter of inner root sheath is more than that of the hair. This is a scalp biopsy, diagrammatic representation of the horizontal section showing numerous anagen or terminal follicles, then vellus hair follicles, and then the telogen hairs. Now this is a cross-section of a terminal hair follicle. You can see the diameter of the hair shaft is bigger than the diameter or thickness of the inner root sheath. Again, we have done here the elastin stain, which highlights the inner root sheath, and the diameter is less than the diameter of the hair shaft. Now, this is a cross-section of a vellus hair. You can see this inner root sheath is thicker than the vellus hair. Vertical section of vellus hair, the short vellus hair are present in the superficial dermis. The hair bulb is located in the dermis and is not in the subcutaneous fat. The terminal hair, the pigmented hair bulb is present in the subcutaneous fat, deep in the subcutaneous fat. Now, this is the section through the Adam's fringe. Adam's fringe is the place in the lower segment with the junction of stem above and bulb below, where there is a start of loss of keratohyaline granules in the inner root sheath, and the hair shaft become acellular, anucleated. The keratohyaline granules of the inner root sheath are lost, and at the Adam fringe and the hair shaft lose their nuclei. Hair shaft and the stem. Note the medulla and cortex of the hair shaft. Medulla is the central portion, cortex is the outer portion, and there is no nuclei in the hair shaft. Now the hair fiber. This is a cross-section through a hair fiber, which is made up of 3 cell layers. The outer layer is the cuticle, which is brown, which is dark brown in color. Then the white color is the cortex of the hair shaft, which forms the main bulk. And the central core is the medulla, which is shown here in pink. All these are derived from the highly proliferative cells in the hair bulb, already explained. Cells in the hair bulb also give rise to the inner root sheath that surround the hair fiber. Outer root sheath is surrounding the hair fiber. Then the cuticle of the hair shaft, formed initially as a single layer, but later on progressively imbricated tile-like multi-layer structure is formed. In fully formed hair shaft, cuticle consists of 5 to 10 overlapping cell layers and 350 to 450 nanometer thick. The important protective property of the cuticle. The cuticle of the hair shaft is a barrier to physical and chemical insult. So if we do a procedure on hair like rebounding, etc., it damages the cuticle and ultimately damages the hair shaft. And the cuticle maintains the integrity of the hair shaft. So wear and tear from cosmetic procedure result in gradual degradation of the cuticle, which is the withering, with breaking and lifting of the free margin of the cuticle cells, leading to exposure of the cortex and fracture of the hair shaft. Now the hair cortex. The cortex has hard alpha keratin intermediate filament, alpha KIF, which is the major structure component of the cortex. The keratin filaments are cross-linked. You can see these cross-links to keratin-associated protein and form a matrix between the filaments. More than 60 hair keratin-associated proteins are known, and having 3 major families: the proteins having high sulfur content, ultra-high sulfur content, and high glycine tyrosine proteins. The hair medulla. The hair medulla is a variable structure. It is not constant. And it may be continuous or discontinuous or absent. The hair follicle innervation. A plexus of longitudinally aligned sensory nerves surround the isthmus. Several different types of nerve endings are found, which are the free nerve endings, the Pylo-Ruffini nerve endings, and Merkel nerve endings. Now the hair cycle. The hair follicle is not a fixed structure. There is continuous changing in the hair follicle at a specific time period, and these changes are called as the hair cycle. So mainly there are 3 kinds of hairs in the hair cycle. The first is the anagen hair, which are the normal terminal hairs. Then the second is the catagen hair, and the last is the telogen hair. So there is a gradual transition from anagen to catagen to telogen, and again the cycle repeats. The telogen hair regenerates into an anagen hairs. Hair cycle is a repetitive sequence of growth and rest. The anagen. This is period of active hair growth. Duration of the phase is responsible for determining the final length of hair. If the duration of anagen is more, hair continue to grow and may take a lot of size. But if the duration is short, hair automatically weathers off after a certain period of time. Under normal circumstances, 80 to 90% of the hairs are in the anagen phase, in the scalp particularly. Start with mitotic activity in epithelial cells overlying the dermal papilla. So this is an anagen phase. A normal terminal hair follicle gradually converts into a telogen phase. You can see the bulb narrows and is lost, and the hair shaft gradually goes up, and the hair bulb and the suprabulbar segment constricts and gets narrowed. In telogen phase, there is completely loss of the stem. Then again, the regeneration develops the bulb goes deeper, and then the normal hair dermal papillae forms, and the new hair starts emerging. And in the meantime, the old hair is shed. The developing hair bulb partly envelops the dermal papillae. Epithelial cells in the hair bulb undergo vigorous proliferative activity and differentiate in an orderly fashion to form layers of inner root sheath and the hair shaft. Now, briefly, the catagen phase. As the epithelial cell division declines and ceases, the follicle enters into an involutionary phase known as the catagen phase. In catagen phase, the proximal end of the hair shaft keratinize to form a club-shaped structure, and the lower part of the follicle involutes by apoptosis. Basement membrane becomes thickened and corrugated to form a glassy membrane. Here. Then telogen, the period between the completion of the follicular regression and onset of the next anagen phase is the telogen phase. There is another phase known as the exogen phase. This is a phase in which there is shedding of club-shaped hairs and is an active process. The tenogen phase is the late stage in human scalp. Hair follicles may remain in this stage for a prolonged period of time after the club-shaped hairs are lost. Now, few words about the rate of hair growth. Scalp hair growth is the maximum, and the scalp hair grows at the rate of 0.3 to 0.5 millimeter per day. It is slightly faster in adult women than in men. At male beard, the size of the hair follicle is, the rate of growth is 0.27 to 0.38 millimeter daily. While vellus hair growth is much slower, it is 0.03 millimeter daily, especially on the forehead. So in a scalp, the anagen phase usually lasts more than 3 to 5 years, and 88 to 90% of hairs are in anagen phase. Then the resting phase or catagen phase lasts for 4 weeks, and 2% of hairs are in catagen phase. Then telogen phase lasts for 3 to 4 months, and 8 to 10% of hairs are in telogen phase. Then from the telogen phase, there is again return to the anagen phase. The hair follicle in catagen phase, horizontal and vertical sections. Note that involution of the follicle in the horizontal section, and keratinization highlighted in the deep red around the hair. This is keratinization. Hair follicle in catagen are surrounded by a thick basement membrane. In catagen are surrounded by a thick basement membrane. This is a thick basement membrane. This is a thick basement membrane. Hair follicle in telogen phase. Note that the collapse of the follicular structure. So here in telogen phase, the central follicular structure is lost, and only epithelial component is left. Collapsed follicular structure. This is the follicular stela, horizontal section with the blood vessels mixed with connective tissue. Now you can see the horizontal sections, diagrammatic as well as real, of terminal hair follicle or anagen phase. You can see large hair shaft is seen here. Then the horizontal section through a catagen phase. You can see the homogeneous keratinization here. Then the last is the telogen phase. The hair follicle is completely lost and there is only epithelium in the center. Anagen hair growth. Growth of obvious facial, trunk, and extremity hairs in male and of pubic and axillary hair in both sexes is androgen dependent, you all know. And the androgen is produced from the testes in male, while in female it can develop from adenocortical area and the ovarian sides. The testosterone is the main circulating androgen. More potent metabolite of testosterone is 5-alpha hydrotestosterone. Conversion of testosterone to 5-hydrotestosterone is catalyzed by enzyme 5-alpha reductase. Androgen receptors. The tissue effect of androgen are mediated through binding to the intracellular androgen receptor. Mutation in androgen receptor gene is responsible for androgen insensitivity syndrome. Hair follicle in occipital skin, a site that shows little or no response to androgen, retain their shape-specific behavior when transplanted into the balding scalp of the frontal skin. So you can see all the bad effects on hairs as well as the good effects are created by the androgens and the androgen receptors. Mutations in the androgen receptor gene is responsible for androgen insensitivity syndrome. Hair follicle in the occipital skin lacks the androgen receptor, and such kind of follicles are resistant to hair fall very late, and these follicles are used for hair transplant, and they are extracted and implanted on the scalp. Now, this is the second portion of the talk, and this is the talk on approach to the patient with hair loss. First of all, take the complaints of the patient, note the presenting complaints. Either there is a gradual thinning of the hairs or there is a rapid hair fall. Thinning or shedding with focus on family, genetic, and age. For example, some families develop hair loss quite early, while some develop hair loss very late. This is all genetic. If the hair loss is in patches, then it is alopecia areata. And most hair loss is asymptomatic. Itch, burning, and pain, which is due to inflammation of the itch, burning, and pain, which is mainly due to inflammatory skin diseases, can lead to scarring. Family history. Female patient presenting with pattern hair loss may have the hormonal disturbance. An inquiry about the regularity of their menstrual cycle is important. Shedding. Shedding or telogen effluvium. History of any particular life event or medication that begins a few months before the onset of shedding, severe psychological stress, physical stress, new medications, dieting, and weight loss all contribute to this shedding or telogen effluvium. Then the second part is the clinical examination, a visual assessment of pattern and extent of hair loss. Does patient have a clinical evidence of hair loss? Is the hair loss diffuse or patchy? Is it occurring in distinctive distribution such as seen in patient of hair loss or the frontal fibrosing elytitis? Is there, then in addition to noting where the hair loss is diffuse or patchy, it is important to note that if there is any distinctive distribution. For example, hair loss or the frontal fibrosing alopecia. Then note the hair color, its shine texture, and hair behavior, which is definitely altered by different conditions. When the patchy hair loss is present, it is important to assess whether patent follicle ostia or whether they are lost. Loss of follicular ostia is actually the scarring. Presence of scalp inflammation perifollicular is seen as perifollicular erythema, follicular hyperkeratosis, plugged hair, and pustules or swelling. Hair pull test. It's a useful test in which 20 to 60 hairs are grasped between thumb and index finger from the base of the hair near the scalp and firmly but not forcefully tugged away from the scalp. Number and type of hairs extracted may give a clue to the underlying diagnosis. In more than 10% of hairs are pulled away from the scalp, this constitutes a positive hair pull test and implies active hair shedding. Hair pull test. If the hair break or snap, this may indicate brittleness and hair breakage that may typify the shaft abnormality. Different conditions resulting in different interpretation of the hair pull test. In telogen effluvium, increased telogen hair are extracted from all areas. In alopecia areata, increase in telogen hairs or dystrophic anagen hairs are seen in the affected area. Primary cicatricial alopecia is increase in anagen hair extracted. Loose anagen syndrome, painless extraction of dysplastic anagen hair lacking the root sheath. Trichogram. Trichogram represents a semi-invasive technique for microscopic examination of the hairs plucked from the scalp. So first the hairs are plucked, which shows how brittle the hair are. And then for further evaluation, these hairs are placed on a glass slide and looked under the microscope. This will provide useful information about the state of the proximal end of the hair shaft and the distal end. The trichogram is useful complementary tool for clinical evaluation, diagnosis, and monitoring the treatment response. Anagen and telogen. The anagen hairs you can see in under a microscope will appear longer, while telogen hair appears shorter. Anagen hair will have the uniform diameter, while the telogen hair have thick bulb. There is intense pigmentation in anagen hair and weak pigmentation in telogen hairs. Then another technique is the trichoscopy. Trichoscopy is a method of hair and scalp evaluation by using a dermoscope. In trichoscopy, the hair and scalp structures are visualized at manifold magnification. The trichoscopy allows 4 basic structures to be recognized. So the 4 basic patterns in trichoscopy are the follicular openings, the perifollicular skin, hair shafts, and the vascular structures. First, the follicular opening. You can see in one, regular non-scarring alopecia. You can see the regular follicular scarring. In number 2, there is irregular follicular openings. You can see the loss of follicular openings here, and this is scarring alopecia. Black dots. In alopecia areata, dissecting cellulitis, tinea capitis, and trichotillomania, and the traction alopecia or chemotherapeutic induced alopecia, all will be associated with these black dots at the hair follicles. Yellow dots at the follicle are mainly seen in alopecia areata. Examination of hairs by trichoscopy shows exclamation mark hairs in alopecia areata, comma-shaped hairs in tinea capitis, then hooked hair, flame figures, which are remnant of the pulled hair, are seen in trichotillomania. Lichen planopilaris is associated with the perifollicular scaling, the third thing, the perifollicular scaling. In scarring alopecia, loss of the follicle opening, sclerosis, and telangiectasias. This is the last part, that is the vascular part. Clinical photography should be standardized in terms of magnification, lighting, and position of both subject and their hairstyles. Then lastly is the scalp biopsy. The current practice is to perform 2 4 mm punches. In scarring alopecia, one biopsy is sectioned vertically and other is sectioned horizontally. In non-scarring condition, it is more useful for both biopsies to be sectioned horizontally. Site is important, and you can take a biopsy from the affected area and compare it with the control. So if the biopsy is bisected into two, then even if it is a vertical biopsy, then again it is divided into two. Laboratory cut both biopsies. So this brings to the end of this talk. I hope the hair anatomy, the cycle, and approach would be a little clear to you after this talk. And if you find difficulty in understanding, you can hear this lecture once again, and it will make the things more easier for you. So thank you. Have a good day and see you next week with another edition of my talks. Goodbye then.